everyone. A very good afternoon. Back to, Dr. Nabi and Dr. Shebrolu combination, and you know who was the winner clearly in ECHO versus CMR. Okay, and I think today is just another, addition to that list. But well, mitral stenosis, I would say, is definitely not, a forgotten lesion, I would say, because it's still very much, important to understand the concept. And I'm going to delve into all the details of mainly assessing it, not just from echo perspective, but what it is in the bigger, in the bigger picture in 2026. Let's just get started. Sadly, no disclosures. For online viewers, please don't forget our favorite Twitter handles, and for viewers on live stream, please subscribe and follow DeBakey Institute of Cardiovascular Education. For all our fellows here, please take a look at the QR code. And of course, the focus is going to be on the valve guidelines, which is the 2009 ASC guidelines on valvular stenosis, and also the 2020 updated guidelines for the management of valvular heart disease. What changed since this last time is actually the European guidelines, which came out more recently. We're going to talk briefly about it, but incorporate most of the kind of details from all the updated guidelines as well. And we are looking forward to the the next version pretty soon. Some interesting fun facts in history. Of course, we need to know about when did this all start, right? So can you imagine? It was first described by Dr. Vuesens in 1705, actually, and he described this as a bony transformation of the mitral valve. It was actually the first valvular lesion to be treated by surgery in 1923, the first ever valve disease diagnosed by echo in 1968, and the first ever valve lesion treated successfully with percutaneous balloon valvuloplasty in 1984. And I just couldn't stop from sharing this cute video, which was exercise stress auscultation done in mitral stenosis from the good olden days. Can you believe that? So they used to auscultate, make the patient exercise, and then auscultate again and see the dynamic changes of the murmur, right? I think, when I see this, it makes me feel so blessed that we can actually visualize it as opposed to just hear that. And what do we know in 2026? Let's talk about what we know now. But before, how I always start with a question, what do you think this is, guys? What is this? What am I showing here? Combination of mitral stenosis with ASD. What is the syndrome called? Any takers? Lutembacher syndrome. How about this one, guys? Okay, I can tell you what I'm showing. Mitral stenosis, you see that humongously dilated left atrium. And what are these, guys? Any takers? Okay, I think I heard something. Yeah, recurrent laryngeal nerve paralysis, Ortner syndrome, guys, right? All right, last but not the least, how about this one? Since severe mitral stenosis, of course, mitral phases. Very classic. I know, I know we are, obviously in the world of diagnostic techniques and, all the advanced stuff, but remember, it always starts with a good physical exam. And I think, I think we don't see as many severe lesions these days, but always you do not want to miss that one particular physical exam if it's pretty obvious. All right. Let's move on, and here's an outline of our talk today. We're going to talk briefly about valvular anatomy, the causes and anatomic presentation, the valve area, and other indices of severity in addition to summarizing the grades. So let's talk about what is normal valvular anatomy. First of all, we need to know mitral valve is typically 4 to 5 centimeters square in area, and it's an apparatus, right? We just don't call the leaflets itself as the mitral valve apparatus. What does it include? Of course, it includes the mitral annulus, the anterior and the posterior mitral leaflets, which are arbitrarily divided into segments. And then we have, the chordae tendineae, the pap muscles, very much so form a component of the mitral, valvular apparatus, which is both the anterolateral and the posteromedial papillary muscles. And remember, the left atrial wall and the LV myocardium are also very much part of the entire thing, right? So you also, whenever you're analyzing the mitral valve, you need to remember that the whole component, you need to analyze it. All right, let's take a look at this particular one. What are these here, guys? Basic views, right? So these are basic transthoracic views displaying how the anterior mitral leaflet and posterior mitral leaflet are in relationship to each other. And again, this one is very important. Look at the apical view where you actually show the papillary muscle. You see the papillary muscle and the anterior and posterior mitral leaflets. And you also see how the whole entire mitral apparatus includes all these and the left atrial wall, especially when you're analyzing the pathophysiology. What about this one, guys? Here's a simple MO tracing. That's the early filling. And this is the atrial filling waveform, right? E and A, very much important in analyzing, again, the pattern of E and A in mitral stenosis or in any other mitral valvular pathology is very, very important, right? What about this one, guys? So all of us here do not, hesitate in saying TEE is definitely more, what do you say? How does TEE differ from TTE in the assessment of mitral valve? Resolution, right? So TEE is undoubtedly much better, higher spatial and lateral resolution, for the analysis of mitral valve. So remember, again, whenever you're looking at mitral assessment, you obviously want to get into that surgical view where you put the appendage on the top, on the left, and the, aortic, valve on the top. And remember, this is the most important view to get that incremental data about valvular morphology and anatomy. And again, I think all of you are very well versed with these kind of analysis, right? You obviously want to go through, 0 to 180. Thanks to the 3D TEEs these days, we don't go through the analysis of each and every scallop, on the TEE. But I think, it is important to know that in the background, how basically the valve is cut in each kind of view so that you can make a comprehensive assessment. What are the causes, guys? Right? So I think more and more, in 2026 especially, there is more segregation as to, there is more and more differentiation of rheumatic versus, degenerative mitral stenosis. And I think eventually the guidelines are really going to split them apart because the whole pathophysiology, the mechanism, the assessment, the anatomy, everything is different, right? And also how, the guidelines also are going to change, even from management perspective, how they both are two different entities. Obviously, the foremost one is the rheumatic mitral stenosis, and here you just have a very classic, mitral stenosis case where you have commissural fusion and caudal shortening associated with leaflet and subvalvular thickening and calcification. And the classic echo features, again, everybody here probably knows the hockey stick or doming appearance of the anterior mitral leaflet. And if you think about it, what you really see on the M mode is also very classic, right? You have very thickened leaflets and decreased EF slopes, and you almost see a parallel motion of both the leaflets, which again indicates, how the commissural fusion can contribute to the leaflets not really moving much. And, it's also important because this indirectly shows the decreased EF slope correlates with the degree of mitral stenosis. So important to know those basic features, right? How about this one, guys? So the second classic bucket, like we just talked about, is the degenerative or the mitral annular valvular calcification kind of pathway, right? You can see clearly that there is significant mitral valvular or annular calcification here as well, and it can result in poor cooptation, which can result in mixed mitral valve disease, which is both stenosis and regurgitation. Most commonly seen in elderly patients and also associated with other conditions like hypertension, prior chest irradiation, CKD, and atherosclerotic disease. Again, I think this in itself deserves a separate talk from pathophysiological perspective too, but important to realize that this has a totally different kind of valvular disease, a difficult to treat disease, because it's actually a systemic disease more than anything else. Then we have obviously the other causes, which are the carcinoid valvulitis. As you all know, is actually commonly seen, on the right side, but you can also see on the left side when you have, those liver mets, bronchial carcinoid, and also presence of an intracardiac shunt. And the wide spectrum of radiation valvulitis, which can happen especially in patients who have had radiation early in their 20s for diseases we all know. And again, you see how there is extensive calcification. So radiation valvulitis, what is the key feature we see in radiation valvulitis, guys? It's all that really thickening and calcification of not just the leaflets, but you see the whole aortomitral continuity is thickened. You see that the whole kind of, wherever the radiation, it was exposed more, you're going to see more thickening and calcification in that area. And of course, we have our entire congenital cohort, right? How can we not forget about all those kind of weird names we see, right? Fibrous rings, Schoen complex. There is also this whole kind of, double orifice mitral valve and hypoplastic mitral valve, and the entity of subvalvular parachute mitral valve or hammock mitral valves, right? So these are all like, they come in a spectrum format. They can, kind of happen in, multiple ways. But again, I think some of the big ones we really need to know, right? For example, I think mitral arcade is a classic one, right? Where you actually see that, the whole mitral, all the pap muscles and the chordae are elongated and are actually connected to each other on the free edge of the mitral valve, right? So very classic ones. So, but today let's talk about assessment of mitral stenosis, right? So we'll talk about, 2D imaging and valve anatomy, and then we are going to talk about indices of severity, stenosis and severity gradation, a little bit about associated lesions and modifiers in special situations where a multi-modality approach is probably better. Let's start with 2D imaging and valve anatomy. Always remember, any analysis starts with looking at the valve, directly, right? And again, that will also help not just to analyze what's going on with the valve, but also what's going on with the mitral apparatus like we just talked about. And again, we are also, like I said, we are going to go into the details how we can actually use 2D and Doppler data to assess further. Let's take a look at this one, guys. What is the answer, guys? All right. Did anybody see that? Let's rewind. Look at that. So basically what I was trying to say is don't focus on one determinant, right? So if you focus on one determinant, you're going to miss the big picture. Always look at the big picture, right? Especially in not just mitral stenosis, but any other valvular lesion, you want to analyze it looking at the big picture. Let's start with some cases, right? Obviously, we want to really analyze, each and every case depending on, the big picture like we just talked about. So here's a classic example of a 52-year-old female from Guatemala with shortness of breath. I'll give you the parameters. Take a look at the 2D images. Look at the apical view as well. I've actually deleted the menti.com, so don't worry about it. Let's just shout out the answer. What do you think is this? Pretty classic. So you see the peak gradient is 27, mean is 14, pressure half time of 185, and a valve area of 1. What do you think? Okay? Perfect, right? So severe rheumatic mitral stenosis, and I think nobody would doubt that, right? And one important component of analyzing this is the heart rate as well, right? So severe rheumatic mitral stenosis, no doubts about it. What about this one? We have an 89-year-old female with syncope. Take a look at how the valve looks in this case. And if I give you the numbers, What do you think this is? Okay, I think no doubts about it, right, guys? So severe calcific mitral stenosis, and the heart rate is not highlighted, but it's in 50s, basically, right? So very important to look at classic cases and kind of learn from them as well. And we'll talk about, all the detailed analysis in a little bit. What about this one? 18-year-old with a murmur. How do you think the mitral valve is looking? Okay. Do you see how it's is there like differentiation between the chordae and the pap? It looks almost like it's a curtain, right? So what do you think is that? It's actually mitral valve arcade with congenital mitral stenosis, right? So, and how do we know that? If you actually paid attention, there is actually absence of papillary muscles and shortening of the chordae tendineae. And if you think about it, the subvalvular apparatus was directly attached to the ventricular aspect of mitral leaflets, right? And the classic is the fibrous bridge-like appearance. That's another very common thing you want to look for, especially when you're looking for congenital lesions. All right, let's move on to our next entity. Of course, right? So we want to talk a little bit about valvular anatomy. So I think evaluation of anatomy is a major component of echo assessment of mitral stenosis because of its implication on the choice of intervention and management as well. Most important components are what are those we are looking at here. If you pay attention, what are the big ones, right? Commissural fusion, right? In this case, you're seeing classic subvalvular and valvular thickening and calcification. And then how do we really use, echo to really get into the, assessment of rheumatic mitral stenosis? So we want to assess pliability and splittability, right? And there are multiple scores. I don't want to go into the details, but I think all of you are very familiar with the classic Wilkins score here, right? You actually divide it, the score is ranging from 0 to 16, and you divide it based on the thickening, caudal involvement, and calcification. And what's the cutoff for balloon valvuloplasty, guys? Less than 8, right? So, you want to remember that for optimal results, your cutoff is less than 8. And what about this one? I think we've tried to use much more simplified versions. This is a Cormier score where you actually base it from group 1 to 3 based on calcification of mitral valve of any extent, right? So if there is any calcification, you just say that's group 3. And why is that important? Again, I think, it's mainly to analyze the pliability assessment, right? And of course, we have multiple 3D actually, like scoring, systems nowadays. Basically, you can really analyze each and every segment, and you can also analyze the caudal calcification and thickening as well in detail. So I think I don't want to go into the details, but I think there's more and more data about how 3D analysis is very important. Let's talk about the indices of severe stenosis and severity first, right? So what is the key or landmark of everything, guys, of when you talk about assessment of mitral stenosis? Pressure gradients, right? I think, but then not in entirely, but the main thing is pressure gradients. What else? Of course, mitral valve planimetry, the pressure half-time in certain conditions and continuity in certain conditions. And of course, we have a PISA method. I know probably a lot of people do not know that there is a mitral stenosis PISA method, but there is. Less validated, so we don't really use it. And also, there are a few other important indices we use based on the scenario of mitral stenosis. How can we not talk about the classic one, guys? What is this one? This is basically the mean gradient, right? Thankfully, what is, normally, when we put the computer data, you basically get a Doppler signal, and the computer fortunately analyzes it and gives you the mean gradient. Otherwise, you actually have to look at every data and you have to look at the mean. But normally with, the updated systems, we basically get the mean gradient directly. And, what about this one? I think a very classic discussion, right? What are we looking at here? So remember, mitral stenosis was one of the conditions where actually a lot of cath data was available from 1960s. And if you think about it, there was this whole cath versus Doppler gradient discussion based on how the mean mitral gradient or in the simple sense, mean pulmonary capillary wedge was not directly equal to mean LAP, right? Thanks to echo right now, where you actually get a live mean analysis of everything. And how is it different, guys? Why is it different? Do you know about this whole classic cath versus echo? So when we are measuring the cath, what are we doing? We are measuring the peak instantaneous gradient, right? So versus echo is a Doppler-derived gradient. So there is definitely a difference between that. And also angle issues, right? So Doppler beams can be, they can underestimate based on the angle of the Doppler assessment. So important to think about that, right? And how about this one? What else is the most important pitfall in assessment of pressure gradient? These are very dependent on heart rate and flow conditions, right? I think this particular slide is very, very important, guys. I think because 2026, there is more and more data, how there is whole low flow, low gradient aortic stenosis. There is that similar entity of low flow, low gradient mitral stenosis as well. So I think what we really need to, understand is that assessment of gradients, in mitral stenosis is an important component, but not entirely the only component, right? Because it's very dependent on flow conditions. And if you think about it, even with moderate degree of mitral stenosis, higher heart rates can cause higher transmitral gradients versus lower heart rate and low flow states can cause lower gradients despite the severity, right? So you're all with me with this one, right? So very important, and it's a very important component, especially in the setting of AFib and diastolic stiffening and patients, this whole array of diastolic dysfunction can be affected because of this, right? So important to think about that. And of course, we have, there is this whole entity where you have mean gradient of less than 10 and a stroke volume index of less than 35, like in our aortic counterpart. And also another important thing is, in severe RV dysfunction, right? In patients who have severe RV dysfunction, severe TR, and I think, I like the term metastatic RV in the setting of mitral stenosis, right? I think we need to think about RV and analysis in each of these valvular conditions more closely, I would say. All right, let's talk about this one. I think all of you who have been in the lab who are doing TEs have encountered this problem at least one time. What is this one? Mitral valve double envelope, right? So sometimes when you have mitral stenosis, you see these strong signals, right? You actually see almost this double envelope, appearance on the spectral Doppler. What do you think? What do you think is this? Which one is the real envelope? Which one is the real one, and what do you think is the reflection of the real Doppler signal? So as you can see, there is the brighter inside signal, right? And there is also this kind of lighter outside signal, right? And actually, there is a lot of discussion about, not just from cardiology world perspective, but there was a lot of discussion from anesthesia perspective too, because when they had these patients intra-op, they really analyzed these mitral gradients closely too. So there is this whole discussion about how the signal could have been from the reflection from the backflow of the left atrium versus the actual kind of, higher signal. And there was this whole big kind of Twitter war where they were talking about how the result of hydraulic forces versus the actual gradient. But I think Dr. Hahn's team from New York actually have clearly shown by increasing the gain, actually they could replicate this kind of artifact. So, and what they are suggesting is basically it's just that, when you have a very dense calcified mitral annulus and apparatus, you can have these reverberation of Doppler signals as well and causing duplication. Bottom line is use the inner, the denser envelope for measurements, right, guys? Or what is that otherwise called? It's called the modal velocity, right? The one which is basically the real one. All right, let's talk a little bit about conventional planimetry. Again, I know it's probably not the best thing to do, but in patients, you really have a good visualization of the, of the valvular opening. And again, remember, when you're doing the planimetry, you really want to do it at the tip of the leaflets and not the base, right? So you have to be doubly sure to be really knowing that, hey, this is actually the mitral orifice before you measure that. What about this one, guys? That's the 3D measurement of mitral valve area, right? There is some promising data that definitely it correlates with the real mitral, like with the actual numbers if you really do a good, 3D TEE. And but again, I think we need to remember that all the calcifications and blooming artifacts can happen on 3D as well, limiting the actual assessment of valvular area. And valvular area, as you know, is an important part of the guidelines to assess severity because, again, if you remember, less than 1 is severe, and but the newer ACC AHA guidelines say 1.5 as severe with less than 1 as very severe. What about the concept of pressure half time? I think every one of us have really looked into this, right? All of us know how to really use pressure half time, which is nothing but, what is that in simple terms, guys? It's the pressure interval between in milliseconds, between the maximal mitral gradient and early diastole and the time point where the gradient is half the maximum initial value, right? And again, which conditions do we really use this, guys? Rheumatic mitral stenosis, right? And you remember that classic Garland's formula we use, right? It was a 220 divided by pressure half time. But what's more important is the pitfalls, right? This is something we really need to, on a day-to-day basis. We can't apply this method on every mitral stenosis case because obviously you have, ENA fusion in a lot of these cases. You have decreased LA and LV compliance, especially immediately after balloon valvuloplasty. Remember, you cannot use pressure half time to measure that. And also other conditions like severe AR, and also when the velocity slope is nonlinear, you need to remember that you shouldn't be able to, you shouldn't be using this method. And gradient tracing too, I think this is another important point guidelines reiterate, is always remember the slope, right? You always want to see, sometimes you can also have bimodal slopes too. You want to use basically what's exactly, appropriate. If you see here, look at that, guys, right? You want to use this slope and not these, right? You clearly see how the slope is not, what I mean? It's not, it's all over the place. And how about this one? You can also do the line drawing method, right? You actually say that you look at the deceleration slope or whichever is the most kind of nicer part of the curve, and basically you can, you can back trace it and use that as well. So very important to know that, because even a small error can actually, make major mistakes in the calculation. How about this one? This is the continuity equation, right? Very important. This is what we actually need to use on a daily basis. And how do we get that, guys? So basically, this is the formula. In simple terms, what we do is we calculate the LVOT stroke volume from the LVOT and VTI, and then divided by the mitral valve VTI, right? Obviously, the limitations are an AFib or concomitant MR or AR. You cannot use this. But remember, this kind of holds valid in both, rheumatic and, and calcific mitral stenosis. How about this one? Again, I don't want to go into the details, but all I wanted to say is there is a PISA method which exists for assessment of mitral stenosis. It can be used in the presence of significant MR, but it's less validated, more discrepant, more cumbersome, so I wouldn't really recommend using this in 2026 at least. Let's move on to some special situations, right? Again, like we talked about all these special situations, especially when I say special situations, flow conditions and, and limitations, which are important in the assessment of mitral stenosis. What's the first scenario, guys? When you have pressure half time, which is not kind of going with your continuity equation, right? Very classic. So why? Obviously, shape of the orifice is tubular in calcific mitral stenosis versus dome-shaped in rheumatic. Gradients are not always reliable, right? We just talked about how pressure half time is not always reliable either. Integrating everything into the continuity equation and other parameters is more important. Let's take a look at this. Let's take a look at a simple example here. So you have a very calcified mitral valve. You look at, how basically the annulus is pretty calcified as well. And here you have some numbers. So when you calculate using the pressure half time, what is the mitral valve area? Comes out to be 0.8, right? When you use the continuity, 1.86. Why do you think is that important? Because what happens when there is elevated LVEDP, guys? So imagine a situation where you're analyzing the LA and the LV gradient, right? So if your LVEDP is high, what will happen to the gradient between the LA and the LV? Exactly, right? So that's why is it important? You need to remember that you want to actually look at the LVEDP situation, right? So in the sense that you want to look at LA and LV myopathy or LA and LV kind of, flow conditions before you analyze that, right? Let's look at another one. What's the other most important one? Presence of significant MR or AR, right? That's another common condition when you see mitral stenosis. Remember, in mitral regurgitation, you cannot use continuity. And aortic regurgitation, you can't use pressure half time, right? Because what happens with aortic regurgitation? Your LVEDP is going to go up, which will limit the assessment of the LA-LV gradient like we just talked about. What about this one? I think another common condition, right? Whenever you talk about mitral stenosis, I think atrial fibrillation is a part of it as well. So it definitely limits an assessment of gradients and all the other parameters as well. Obviously, what we can try to do is at least keep an average of at least 5 cardiac cycles with least variation of RR interval, right? And as close possible to the normal heart rate. And finally, don't forget other ones which we need to look at, right? We need to look at the PA pressures, we need to look at mitral valve resistance, and of course, if you have patients who have discrepant symptoms in relationship to what you're seeing on the echo, you want to do an exercise or the dobutamine stress echo. And everybody here, I'm sure they all know, how to really assess valvular stenosis based on guidelines, right? You all know that valve area of less than 1, mean of more than 10, and a PA pressure of more than 50. And these are in the normal flow conditions. If you look, it's between 60 to 80 of heart rate and normal sinus rhythm. And again, I think every one of us know, your symptoms obviously majorly contribute to assessment of, mitral stenosis too. And let's take a quick example here. We do want to give Dr. Nabi some time. So take a look at this. So it's a patient, asymptomatic, 2013. You look at the mitral valve, looks pretty normal, right? Your mean gradient is 2, and your continuity valve, based area is 2.3, and PA pressure is 32. The same patient, 2015 now, look at how the valve looks. Right? Pretty classic. Now your gradients are in 7s at heart rates of 80. Now the valve area is 1.1, and now the PA pressure has gone up to 59. Clearly it's moderate, right? Now imagine the same patient, look at this valve now. Right? Now the patient has exertional dyspnea and exercise intolerance. And now look at the PA pressures. So we say it's moderate to severe calcific mitral stenosis. The same patient, when we subject them to dobutamine stress echo, look at that, guys. So the mean went from 19, increased up to 19, right? So, and when you define it with the DSE, the basically mitral stenosis is more than 15 with exertion or more than 18 with dobutamine, and also the PA pressure change of more than 60. So very classic, right, guys? So you want to really, like what we just did was basically look at all the parameters in relationship to the LV parameters as well, right? All right, finally, we need to give some credit to our multimodality people as well. Of course, TEE is an option when you really cannot see anything on the transthoracic, which can happen quite sometimes, often because these patients are, pretty tough, suboptimal window patients. Invasive dynamics, obviously reserve it when everything else is not really working. And of course, we're going to have, the whole world of CT and CMR as described by Dr. Nabi in a few minutes. So long story short, I really think we need to be very, very, it's important to analyze every aspect of the echo and assessment of mitral stenosis, especially, kind of when you're talking about, preparation for surgery in patients who have these moderate to severe mitral stenosis become a challenge. And always remember, you want to analyze in the setting of moderate, less than moderate MR, and also ruling out left atrial and left atrial appendage thrombus is an important component of these. And if you have favorable anatomy, you have balloon mitral valvuloplasty, versus unfavorable will always go through the surgical or the transcutaneous route. And calcific mitral stenosis, very different, because obviously you have poor prognosis compared to the other counterparts, and intervention is reserved for highly symptomatic patients. And a lot more is coming out in this aspect, guys, so stay tuned on this. But there is decalcification maneuvers which are in progress. There is also this newer LA to LV conduit, which is also, kind of developing right now. And trust me, guys, mitral annular calcium is one which I think is a very high surgical risk, especially because the AV groove can dehisce when you're operating on these calcified mitral valves. So long story short, I think, we need to, I think this is what we need to do. I know I showed the other way around last time, but I think, I put radiology in there too, because sometimes we need to give them some credit. All right, guys, thank you again, okay?
I think I convinced Bindu of the advantages of multimodality imaging. That's why we're all hugging now.
Now we have become friends.
Okay, so we have about 20 minutes, which is a perfect amount of time for the rest of this talk. So, as Bindu mentioned, of course, with any valvular heart disease, echo is the first-line test. A lot of very important information you get out of it, including the etiology, the morphology of the valve, LV and left and right-sided function, PA pressures, LA size, and the presence and absence of thrombus. We know that, a very important test. Now, my goal, of course, will be to show you how the advantages of advanced imaging, such as CT and CMR, can be very complementary to this exam. We know the epidemiology, as Bindu had mentioned, in the developing countries, it's more likely to be rheumatic heart disease as the cause of mitral stenosis, whereas in developed countries where there's a prevalence of antibiotics, such as our own country, the type of mitral stenosis you're more than likely to see here is the calcific type. Now, just as she had mentioned, these are different diseases and different treatments, and it's important to be able to recognize both of them. And this is just a kind of a table that goes over the differences between this. But what I want you to know is, at least for rheumatic mitral stenosis, again, these are it's the number one cause of mitral stenosis in the developing world, and general presentation is usually around the 60s or 70s, which I guess we consider relatively young. Calcific mitral stenosis, if you just look at that picture, this is really a disease where you have multiple organ systems involved. These are advanced patients who are quite ill. They'll have all your cardiac risk factors or risk factors for atherosclerosis, which we believe is also the risk factors for the calcification that develops at the mitral annulus and the mitral valve leaflets. So two very different kind of groups of people. Now, if you look at the guidelines, Bindu did a nice job for me, was that you can see how this valve, unlike the aortic valve, is very flow dependent, very hemodynamic, dependent on hemodynamics. So if you look at treatment guidelines, everything is based on the mitral valve area. So here's from the ACC, mitral valve area less than 1.5, and the same thing with the 2025 ESC. So everything is based on your valve area. Well, we know there are different ways, as Dr. Sherblu had shared with us, how with echo you can derive a mitral valve area. She went over the continuity equation, she went over polinimetry, she went over pressure half-time, and also 3D echo. And she also went over some of the difficulties with these techniques with echo. For the continuity equation, you know that you can underestimate it if you have reduced volumes, and it's definitely unreliable when you have significant MR or AI. Same with gradients, again, very flow dependent, and the pressure mitral valve area polinimetry can be very compromised by all the shadowing that you get with calcium. And for the pressure half-time, as you know, it's very flow dependent, and it really depends on LA and LV compliance, which can be significantly affected by both AI and MR. So, my point being is, at the end of the day, we have to derive an accurate mitral valve area, but we have a lot of difficulty with some of the different echo techniques. So why not, and you may have bad windows, and your patient may be obese, et cetera, et cetera. And this is where, techniques such as CT and CMR can be very helpful. We've already discussed a lot of their advantages, their very high spatial resolution, the ability to see large field of view, the ability to see valvular structures very well, and the ability to directly measure a polinimetered valve area. And that would be its greatest strength. So my job today is just to show you how we can use these techniques for mitral stenosis, and it will be just exactly as Dr. Sherblu did. I'm going to show you how we can use it to identify morphology. We can actually grade the mitral stenoses. We can look at its hemodynamic consequences on the left atrium and backwards towards the right side. And one of the big advantages, at least with CT, is then when something has to be done, specifically in the case of calcific mitral stenosis, planning a therapeutic strategy. So we already discussed the major causes. In the developing country, mitral stenosis is the number one cause. Here's just an example of that. We went over some of the salient features of this. You get commissural fusion. As a result, you get this hockey sticking appearance of the anterior mitral valve leaflet. The leaflets may be thickened. The chordae may also be thickened and appear shortened, and you get this fish mouth appearance on your short axis images. This is a particular case where not only do you have some mitral stenosis, but if you see, there's also a regurgitant jet as well. With Wilkins score, of course, this has been developed with echo, but we do have the ability to, ability to at least determine thickness. Look at the subchordal apparatus. You can see just in the way this valve is moving, it's much more, the leaflet mobility is significantly much more compromised compared to the last echo I showed you, CMR I showed you, and the valve also appears markedly thickened. So you can at least get an idea where you may be in your Wilkins score. It's very important to realize that patients who have rheumatic mitral stenosis may also have involvement of the aortic valves, and this was such a patient. You can see the hockey sticking and the commissural fusion here, and as well as the aortic insufficiency, likely due to, again, commissural fusion of the aortic valve. When it comes to patients in developed countries, severe senile or calcific degenerative mitral stenosis is the number one cause. A technique such as CT which sees calcium with a great ability, can very nicely show you the severity of calcium that's present, the distribution of the calcium. This can be all very important for planning of if any future procedure that may be performed, whether surgical or percutaneous. With calcific MS, as we had already discussed, this is usually a condition of the elderly. Usually these patients have multiple comorbidities. In addition to mitral stenosis, it generally tends to have a very poor prognosis with a 5-year survival less than 50%, again, due to the baseline characteristics of these patients. It is known that patients who undergo a TAVI for aortic stenosis would often have significant mitral stenosis, and in one series of patients, 50% of patients had some degree of MAC, and the disease was severe in about 10%. And as Dr. Shrublu had mentioned, unfortunately, any treatment we have for this disease is not without risks. So can we see calcium with a CMR? Calcium is not a hydrogen ion, so we can't necessarily image it directly. However, we do see, and especially this very nodular chunky calcium, that it appears as these dark signal void areas. So yes, I may not be able to directly see calcium with CMR, but the fact that you have these areas of signal void at the annulus, extending around posterior annulus, this is all very characteristic of a calcium, and hence we can make the diagnosis of calcific mitral stenosis, such as in this case. As I had discussed, it's very important when you do see patients with calcific mitral stenosis, take a look at the other valves. It's not unusual, to have aortic stenosis as well, such as in this case. Again, because the disease process is this kind of, inflammation of the leaflets that leads to stenosis of both valves. We had discussed other causes of mitral stenosis, and this was just a case that was recently done in our own lab that I had to share with you, where you had this very large myxoma obstructing inflow through the left side. Now, how do we grade severity? This is, I think, the strength of these complementary techniques, is that we have the ability to directly measure the valve area. How do we do this? We want to measure the leaflet orifice opening at the narrowest portion. So with CMR, what we can do is we can create several slices at the leaflet tips using our long axis views to create a true short axis of the mitral valve opening. And then, so you can see that kind of in the short axis slices at the bottom of the screen. And then we would go and individually measure the maximal opening in diastole of the mitral valve. And the mitral valve area then would be the smallest opening that we identify at the leaflet tips. And in the end, it would be something just like that. You were able to very clearly identify the borders of flow and the leaflets, and clearly make a measurement of deriving both perimeters, areas for these leaflets. Similarly, this has been, again, small studies. Take it, for what you may. This mitral valve area has been compared both to echo and cath. What's important to know, just as we had mentioned with aortic stenosis, that the planimetered anatomical valve area for the mitral valve is always larger than the effective orifice area that is obtained by Doppler gradients using echo. So what about with CT? This is just a great example that, because we have the ability to do these high resolution NPRs, we just get, we find our, we need a multi-phase data set. So we want to, get an entire retrospective CT on these patients. We'll go to our diastolic phases. We'll go right, create again, using our long axis views, a double oblique of the mitral valve opening, and we're able to very accurately quantitate a mitral valve area. And this is just an example from our lab of me doing this on a particular patient. This by CT has also been compared to echo and the cardiac cath lab, and again, found very good correlation. But again, the same findings were observed that when you do planimetry, when you planimeter an anatomical area, it's always slightly larger, about 10% larger than the effective orifice area obtained by Doppler equations. So when should you consider these advanced techniques for mitral stenosis? So I think Dr. Shirublu gave us some great examples. Whenever you have a discrepancy between your clinical findings, your hemodynamic findings, and what your patient is telling you. And some of the places where I think it can be very helpful are in patients where you have combined MS and MR. As we've already discussed, pressure halftime is going to have problems with this because of compliance issues of the left ventricle and left atrium, and the continuity equation will also be problematic. So this is a great situation where we can just directly measure the valve area for you. What about MS and AI? Similar situation as to the patient that has MR. You have pressure halftime continuity equation become a little bit problematic, and so a direct perimetry can be very helpful for you. What about hemodynamic consequences to structures upstream from the mitral stenosis? We can very accurately, both by CMR and CT, measure LA volumes for you. We're able to, by CMR, as you know, a great technique for tissue characterization, this, identify thrombus versus masses that may be seen in the left atrium. And this was an example of really a giant LA thrombus. CT, similarly, is a fantastic tool also for looking for thrombus. We use a delayed phase protocol where we'll do a repeat non-contrast image at 60 seconds, looking to see whether our mass has perfused or not. If it has not perfused, then very likely this is a thrombus. And this was another example of a patient with mitral stenosis with a very large thrombus in the left atrium. LV and RV function, these techniques by now are really the gold standard, and are probably well versed of how we go about obtaining values of volumes and function, both for the left and right side. And finally, though we cannot measure pulmonary pressures directly with a CT or CMR, there are a lot of secondary features that we can look for, such as flattening of the septum, RVH, RV dilation, RV depression, PA size. These are, a dilation of the IVC, hepatic veins, reflux of contrast in them. These can all be signs of potential elevated right-sided pressures and PA pressures. Finally, when it comes to procedural planning, when it comes to rheumatic mitral stenosis, the treatment is most often a balloon commissurotomy. This is all based on patient's symptoms and valve area. There are some contraindications that are, you should be aware of. Of course, if you have thrombus there, that's not a technique that you want to be doing. And then if you have significant calcification, which could lead to tearing of the leaflet and resultant mitral regurgitation, those may not be the best techniques. For calcific mitral stenosis, as you know, this is a real problematic condition, as was mentioned. The surgeon has real difficulty because if they try to peel off this calcium, they may not have any annulus left, so it can be really difficult, leading to a lot of, MR and long surgery times. For the interventionalists, it's a real problem because we don't have dedicated treatment valves yet for this disease. We're using, sapien valves in MAC currently, but you have issues as distal embolization potentially and LVOT obstruction. So it's a challenging condition. And then at the end of the day, even if you had a successful surgical outcome or procedural outcome, at the end of the day, you have the baseline patient that you were dealing with who tends to be very elderly, debilitated, and often with multiple other comorbidities. So there are a bunch of percutaneous devices. Most of these are for mitral regurgitation. We're using the Edwards sapien, but the point being is, all of these devices, they all require very accurate measurements of the annulus. And this is where CT is king in this arena. It can be very accurate in determining mitral size and geometry, looking at landing zones, trying to predict if you'll have LVOT obstruction, helping surgeons with the fluoroscopic angles, so they're coplanar with the mitral annulus, and then of course axis planning. So this is really where CT becomes king when you're considering some sort of percutaneous procedure. As we had mentioned, visualizing the MAC is very important. Making these measurements that we do in the lab every day are very important. We kind of simplified the mitral annulus is a complex structure. It's a saddle-shaped structure. We kind of simplify it into these D-shaped kind of annulus, and these measurements, such as the intercommercial and trigone to trigone measurements, become very, very important. And this is just an example with CT. There's a lot of software now that can automatically do these and bring you correctly into the right position. Now, this is just an example of us looking at particular, landing zones assessments, which are also important. Now, one of the biggest things is, with these valves, you can imagine that, the anterior leaflet gets pushed towards the septum, and as a result, you could compromise flow through the LVOT. This is called the neo-LVOT. And with CT, you can actually kind of model what, if you were to place a valve there, the different types of valve that you were considering, what that neo-LV dimension would be post-procedure. And there's no established validated cutoffs, but what we do know is that you want to have an area of at least greater than 200 millimeters squared when you're done with the procedure. So CT can be very helpful in predicting who will have that sufficient area left post-procedure. And this is just an example, of a patient where it was predicted to have an area of 1.5 with the valve, and sure enough, post-procedure, the patient was left with a 1.4 centimeter area in the neo-LVOT. Finally, other factors we can look for that increase our risk of LVOT obstruction. The aortal mitral angle is very important. Whether you have a lot of basal intraventricular septal thickness, which we can measure, becomes very, very important, as well as the anterior mitral leaflet length. Finally, no talk in CT is complete without the ability to look at other things that can be very important, such as coronary anatomy, planning the transseptal procedure, looking at the peripheral vasculature to be able to get your device to its correct location. Although maybe not as much done now, you can actually plan even your transapical procedure. So I hope I've given you a good overview of CT and CMR in the use of mitral stenosis. And Dr. Sherblu and I thank you for this opportunity, and we've gotten you done in time. And if you have any questions, Dr. Sherblu would be very happy to answer them.